The fastest hands alive. What surgery was like before anesthesia. Opening hook. You're lying on a wooden table. The room smells like blood and sawdust. There are men holding your arms down. Men holding your legs. A stranger is standing over you with a knife. And everyone in this room, including the man with the knife, is moving very, very fast. Not because they're panicking. Because speed is the only mercy they have to offer you. You are about to have surgery. It is 1843. And you are completely, horrifyingly awake. ## full narration script. Here's something most people never think about. Every surgery in human history, every one, for thousands of years, required the patient to be conscious. No sleep. No numbness. No escape. Just you, the blade, and whatever willpower you had left. We have anesthesia now. We've had it since the 1840s. So we don't think about what came before it. We assume it was brutal, primitive, fast, and ugly. But that's only half the story. Because what surgeons did before anesthesia, the way they adapted, the systems they built, the terrifying brilliance they developed, is one of the most fascinating chapters in the history of human ingenuity. And it starts with a simple question no one ever really asks. What did speed actually mean? Imagine you are a surgeon in 1820. London. Edinburgh. Paris. Doesn't matter. Your patient is a man with a gangrenous leg. The infection is spreading. If you don't remove the limb, he dies. There is no other option. No antibiotics. No waiting. You have to cut off a human leg. And the only thing standing between this man and unimaginable suffering is how fast you can do it. So let's talk about what fast actually looked like. The best surgeons of the era, men like Robert Liston, the most famous surgeon of the 19th century, could amputate a leg in under 30 seconds. Not 30 minutes. Not 3 minutes. 30 seconds. Liston was so fast that witnesses described it as almost impossible to follow. His hands moved in a blur. Spectators in the gallery, yes, surgeries had spectators, would blink and miss the cut. The limb would simply be gone. People called him the fastest knife in the West End. And they meant it as the highest possible praise. Because speed wasn't about showing off. Speed was the only painkiller they had. But here's where it gets complicated. Because fast surgery sounds simple in theory. In practice, it was one of the most technically demanding things a human being has ever attempted. Think about it. A conscious, terrified patient is not a still patient. They scream. They thrash. They pull away from the blade. They go into shock. They faint at the worst possible moment. They can have a seizure from the pain. So the surgical team didn't just need a fast surgeon. They needed a system. And the system they built was extraordinary. Most operating teams had 4 to 6 people. Not just standing around, each person had a specific, choreographed role. 1 man held the shoulders. 2 held the legs. Someone managed the tourniquet. Someone else tracked blood loss. The surgical assistant prepared the ligatures, the threads used to tie off blood vessels, in advance, holding them in their teeth, ready to hand them to the surgeon without a single wasted second. Every movement was drilled. Rehearsed. Refined. It looked like chaos. It functioned like a machine. And before any of this began, there was one more thing to handle. The patient. How do you prepare someone to be cut apart while they're awake? This is the question nobody wants to think about. But surgeons had to think about it every single time. Some patients were given alcohol. Enough to blur the edges but not enough to actually stop the pain, because too much alcohol could cause other problems, erratic behavior, increased bleeding, dangerous reactions. Some patients were given opium. Or laudanum, a mixture of opium dissolved in alcohol. This helped. But it didn't eliminate pain. It just made people slightly less present for it. And then there was a technique that gets almost no attention in history books. Surgeons talked to their patients. Not to comfort them. Not to distract them. To control them. The best surgeons understood something crucial: a patient who was mentally prepared would hold still longer. Would last longer before panic took over. Would survive the procedure with a better outcome. So surgeons developed something that was part ritual, part psychology, part sheer force of personality. They would walk in with absolute calm. Absolute certainty. They would speak in a low, steady voice. They would explain, briefly, deliberately, exactly what was about to happen. They would make eye contact. They would project the idea that this was normal. That they had done this 1,000 times. That everything was under control. Because the moment a patient panicked, the surgery became exponentially harder. And harder surgery was slower surgery. And slower surgery was more pain. This psychological ritual, this art of projecting calm in the face of horror, was considered a core surgical skill. Just as important as the knife technique itself. But even with all of this, even with the drilled team, the alcohol, the opium, the psychological preparation, the reality was still brutal. Let's not flinch from it. Patients screamed. Of course they did. Some passed out from pain. Some from blood loss. Some simply from the shock of it all. And here's the part that almost nobody knows. Fainting was sometimes considered a mercy. If a patient lost consciousness from pain, the surgery continued anyway. There was no stopping. No pausing. No checking in. Because the clock was still running. The longer the incision stayed open, the higher the risk of what they called mortification, what we now call infection. Every second of delay was a second the wound was exposed to air, to the environment, to everything. So a surgeon who stopped when a patient fainted was a surgeon putting that patient at greater risk. You kept cutting. You kept moving. You didn't stop until the procedure was done. And then, only then, you assessed the damage. Now here's the part of this story that completely changes how you see these men. We look back at pre-anesthetic surgery and we think, barbarians, we think, primitive, we think, thank God we don't live then. But that's not what the surgeons thought. They didn't see themselves as inflicting suffering. They saw themselves as limiting it. Every technique they developed, the speed, the drills, the psychological preparation, the specialized tools, was specifically designed to reduce how much a patient suffered. The fastest surgeons weren't celebrated because they were impressive to watch. They were celebrated because they saved lives. A 30-second amputation versus a 5-minute amputation was not just a time difference. It was the difference between a patient who might survive and a patient who almost certainly wouldn't. And the surgeons knew it. Robert Liston, the man with the 30-second leg, he cared about his patients intensely. He studied. He practiced. He obsessed over technique. He lost sleep over deaths. He pushed himself to be faster, cleaner, more precise, not for glory but because he understood that every tenth of a second he shaved off that procedure was a tenth of a second less agony for a fellow human being. That changes things, doesn't it? But here's where the story gets darker. Because speed had a shadow side. In the race to be fast, to be the fastest, a competitive culture emerged in surgical theaters. Surgeons were watched. Judged. Ranked. The best ones became celebrities. Medical students traveled across Europe just to watch them operate. And under that pressure, under that scrutiny, some surgeons began to push speed past the point of safety. Robert Liston himself is famous for something that no surgical history account can resist telling. The only surgery in recorded history with a 300% mortality rate. During one procedure, Liston worked so fast that he accidentally amputated 2 of his assistant's fingers along with the patient's leg. Both the patient and the assistant later died of infection. And a spectator, watching from the gallery, was so convinced by the spray of blood that he'd been stabbed, that he went into fatal cardiac arrest from shock. 3 dead. 1 surgery. No anesthesia. It's almost unbelievable. But it's true. And it tells you something important. The pressure to be fast created its own kind of danger. Speed was the solution, and speed was the problem. So what happened when surgeons had to operate on places that couldn't be fast? An amputation could be done in seconds. But what about a bladder stone? What about cataract surgery? What about, and this one will make you wince, brain surgery? These procedures existed before anesthesia. They had to. People got bladder stones. People got cataracts. And the only option was to operate. Bladder stone removal, called lithotomy, was considered one of the most painful surgeries ever performed on a conscious human being. There was no way to make it fast. The anatomy didn't allow it. The surgeon had to work carefully, methodically, in a body cavity, with a patient who was in absolute agony the entire time. Some patients were given strong doses of opium beforehand and essentially pushed beyond the threshold of consciousness. Some were restrained so thoroughly they could barely move a finger. Some bit down on leather straps, which is where the phrase, "bite the bullet," actually comes from, because the alternative was biting off your own tongue. And the surgeons who performed these procedures were not celebrated for speed. They were celebrated for something else entirely, the ability to work with absolute calm and precision while a human being screamed beside them. That is a different kind of skill. That is almost a different kind of person. There's something profound buried in all of this that we need to talk about. Because when we look at what these surgeons managed, the systems, the speed, the psychology, the precision under unimaginable conditions, we're really looking at something much bigger. We're looking at what humans do when they face a problem they cannot fully solve. They couldn't eliminate pain. They didn't have that option. So they built everything they could around pain's edges. They minimized it. They managed it. They developed techniques so refined that even within the brutal constraints of what they had to work with, they saved lives that would otherwise have been lost. This is a pattern that runs through all of human history. Not, we solved the problem. But, we couldn't solve the problem. So we built the best possible system around it. And then, years, decades, sometimes centuries later, someone comes along and cracks it open entirely. That crack happened in 1846. October 16th. Massachusetts General Hospital. A dentist named William Morton administered ether to a patient before a surgical procedure. The patient felt nothing. The surgeon, John Collins Warren, looked up at the assembled spectators and said, simply, "Gentlemen, this is no humbug." The room erupted. Because every single person watching understood what they had just witnessed. The problem that had defined surgery for all of human history, the problem that had driven Liston to his 30-second amputations, that had pushed assistants to hold leather straps in their teeth, that had filled operating theaters with screaming, was suddenly, completely, irreversibly solved. But here's the thing that almost never gets mentioned. In the years immediately after anesthesia was introduced, surgical mortality actually went up. Not down. Up. Why? Because when patients could no longer feel pain, surgeons lost their most powerful incentive to work fast. And slow surgery meant longer exposure. Longer exposure meant infection. And in 1847, without antibiotics, without germ theory, without antiseptics, infection was the real killer. Surgeons had spent generations mastering speed as a form of protection. Now they had anesthesia, and they thought, we can take our time. And patients started dying of infections that never would have had time to develop under the old system. It took another 2 decades, until Joseph Lister's antiseptic methods in the 1860s, for surgery to fully become what we recognize today. The full picture only arrived in pieces. And those pieces cost lives. ## final closing thought. We remember pre-anesthetic surgery as barbaric. And parts of it were. But the men who practiced it weren't barbarians. They were problem solvers operating at the absolute edge of what was possible. They built speed into an art form. They turned teamwork into choreography. They used psychology as medicine before anyone called it that. And when the breakthrough came, when ether and chloroform finally arrived, those men did something remarkable. They let go. They didn't cling to the old ways. They didn't insist that fast surgery was still the right surgery. They adapted. Almost immediately. Because the goal was never speed for its own sake. The goal was always to reduce how much a human being had to suffer. Speed was just the best answer they had until a better one came along. And maybe that's the real lesson buried inside all of this. We look at the limits of our own era, the diseases we can't cure, the problems we can't solve, the situations we can't fix, and we feel helpless. But humans have always lived inside limits they couldn't break. What we do, every single time, is build the most extraordinary systems we can within those limits. And then we wait. Because somewhere, in some hospital or laboratory or workshop, someone is holding the next veil of ether. They just haven't used it yet.